All right, and so for those of you all who don't know me, I am Dr. Presley Boyd. I teach health assessment, funds to Adult Health One, and Patho. So I may run into some of you all again if you have never seen me or heard of me before. A little bit about my background. I've been in the nursing field for a little over 6.5 years. Started out my journey. I went to Florida A&M University for my degree. Started out as an ICU nurse, as a grad nurse. I started out in ICU. I did travel nursing. I did hurricane disaster relief nursing. I became a nurse practitioner in 2018. I also started doing some teaching, clinical instructing in 2018. And now I teach and I still practice as a nurse practitioner. So that's a little bit about me if you've never heard of me or met me or seen me in passing before.
Oh my God.
So says I have about 32 people. I only have 21 people on the Kahoot. So if I can get more of you guys to log into the Kahoot, please. All right, let's get started. All right, so Alice complains of waking up at night with shortness of breath and needing to sit up to breathe. This condition is called. So one person said dyspnea, 6 said orthopnea, and 18 said paroxysmal nocturnal dyspnea, which is the correct answer. So can somebody tell me why the answer is not orthopnea? Is there anything that leads you in this question that leads you to know that this would be paroxysmal nocturnal dyspnea?
Wake up at night, cannot
At
breathe.
night, right? Okay, waking up at night. So the definition of paroxysmal nocturnal dyspnea is for someone that wakes up at night with the inability to breathe. Okay. Orthopnea is when someone is lying flat and they have to sit up to breathe. The key defining factor in the answer for this question is waking up at night. So and then reading the name for paroxysmal nocturnal, which means at night dyspnea. So the name in the definition kind of gives it away, but whenever you look at questions, look for your keywords. Okay, what makes this more right than the other one? So yes, orthopnea is when you can't breathe and you need to sit up, but paroxysmal nocturnal dyspnea is when you have issues with breathing at night and you have to get up. Okay, so that's the difference. Everyone understand that? I'm not sure I can see the chat. All right. Can someone tell me what pernicious anemia is?
Vitamin B12, lack of vitamin B12.
Lack of vitamin B12. And let's see. I mean, vitamin B12. I'm going to start calling on people because Suzanne is the only one answering me right now. So let's see. Aaron, Carrie, how does someone get pernicious anemia?
Something with like the B12 not being absorbed, or
Okay, so in your older adult, what causes B12 to not be absorbed?
It's the it's with the liver, I think, the decrease and
Anybody want to help her out?
yeah, help me out.
Phone a friend. Let's see.
Is it because of their GI system is not really intact how it used to be? They're older, so their lining of their stomach is not really absorbing how it should.
Okay, we're getting closer. So something about the lining of the stomach. Anybody know what happens to gastric secretions in older adults?
It's decreased.
It decreases.
Decreased gastric secretions. So in older adults, they have decreased gastric secretions, and that can lead to pernicious anemia because they have an inability to absorb vitamin B12. Y'all remember that?
Yes.
All right, so decreased gastric secretions is what causes pernicious anemia in older adults, and pernicious anemia is low vitamin B12. Okay. All right, we're split on this one. So presbycusis is a conductive hearing loss in older adults. So let's see. Veronica Ortiz, are you on?
Yes.
Can you tell me why this was false?
I think it has something to do with the term conductive. I'm trying to look it up as like the difference between different types of hearing loss. I just remembered that presby related to older adults.
Okay, presby is related to older adults, and it's some type of hearing loss in older adults. And so when we learned about our hearing losses, we either have conductive or what's the other type? Does anyone know?
Sensorineural.
Sensorineural. Okay. So if this is not a conductive hearing loss, then what type of hearing loss is it?
Sensorineural.
Okay. And so tell me the difference between the two. Conductive hearing loss is what?
A barrier.
So typically some type of blockage or structure is preventing the hearing. And if we remove that blockage or that structure, the hearing will be restored, correct? Yes. Whereas with sensorineural hearing loss, what's happening?
Nerve damage.
Nerve damage. And when nerves are damaged, do they regenerate?
No.
No. So conductive hearing loss is a type of hearing loss that they can come back from, whereas sensorineural hearing loss is permanent. Okay, and we know that it's permanent because it is a degeneration or destruction of the nerve cells or the nerve fibers in the ear. Okay, they can't come back from that. Understand the difference?
Yes.
All right. All right. So all of the following are age-related changes of the nose and mouth. So we have dry mouth and sense of taste. Do they have an increase or decrease in smell?
Decrease.
Decrease. And then we should not see bleeding gums in older adults. That's not an age-related finding that we should see. So always think about your normals versus your abnormals. Of course, my biggest lecture with your older adults is low and slow. Okay, everything is low and it slows down. All right. So just keep that in the back of your mind for your older adults. All right, so this is false. And kind of, I just told you the answer before this one because I told you guys everything is low and it slows down. Okay, so typically you don't see anything increased in your older adults. So older adults become fatigued during exercise due to decreased cardiac output. Okay, so as we age, the heart ever so slightly slows down its function. It's old, literally just old. Okay, and so when that happens, when we exercise, it causes our heart to work harder. All right, but because we're older and our heart is older, it cannot meet the demands of the exercise. So that means that when we're exercising, really our heart needs to pump more blood, but because the heart is old, it can't put out as much blood as it needs to meet the demand of the exercise. So because of that mechanism, you'll see that your older adults get way more fatigued during exercise because of that. Does that make sense?
Yes.
All right. How's this going for you guys so far? Bringing in some information about some concepts that you guys have discussed.
Yeah, it's helpful.
Okay. Let's keep moving. All right, presbyopia is age-related eye disorder that affects central vision, and that is false. So what is presbyopia? What does it affect?
The eyesight.
The eyesight, how?
Isn't it near vision?
Near vision. So typically this is your patient that has to read with the magnifying glass, so they need larger print books. The problem with presbyopia, what causes it is they have a decrease in their lens elasticity. Okay, the issue with presbyopia is their lens elasticity causes an issue with them being able to see near. Okay. Anybody know what the name of the age-related eye disorder that affects central vision is?
Macular degeneration.
Macular degeneration. Okay, that's macular degeneration. So presbyopia is your issue with not being able to see things close up. And it's caused by a decrease in your lens elasticity. Okay. Also, if we are going through this Kahoot and these concepts you're getting incorrect or you're not understanding, please make sure that you go back and review them. Okay. And also, if you guys have any questions, feel free to stop me at any time. All right. So when you get to your exam, one of the things I want you guys to do is make sure you read, okay? Because you have two terms. You have dysphagia with an S and you have dysphagia with a G. Okay, so S and G. Dysphagia with a G is going to be difficulty swallowing. Dysphagia with an S is going to be difficulty communicating. Okay, so make sure that when you get to your exam, whenever you're taking a test, that you read thoroughly your terms. Okay, you don't have any questions about this. What is, if we're talking about dysphagia with the G and its difficulty swallowing, what is the issue with that? Why are we concerned about someone having dysphagia with the G?
Aspiration.
Aspiration. Okay. And aspiration affects what system?
Lungs.
Story.
Our lungs. So how high is aspiration on our priority list?
Number 1.
Number 1. All right, because that is something that is affecting our airway. So always remember your ABCs. Whenever you guys get to your exams, make sure for prioritization purposes that you can write down in a corner somewhere ABC, so that you remember to always approach a situation understanding what is most important to what is least important. But with aspiration, difficulty swallowing, that affects our airway, so that's a top priority. All right. All right, this is false. Okay, so this is going to be, if you want to know, if you got this question wrong, you want to review this is going to be on page 703 in your book. It's going to be the urine color and discolorations. It's a wheel and it shows you the different colors that urine can be and what can cause them. So can anyone tell me what may be some causes of pink urine?
Food dye, beets.
Dye beets, okay, food dye and beets. Some type of women can see it with their menstrual cycle. You can see it with kidney stones, UTIs, but most commonly you'll see it with beets and food dyes. Okay, so make sure you guys review that color wheel. It's on page 703 in your book. All right, so you should hear timpani when percussing over an air-filled space. Okay, when should you hear dullness?
Over an organ.
Over an organ or a solid mass. So you should hear dullness over an organ or a solid mass. When do you hear resonance?
Is it with fluid?
With lungs. So that's a lung assessment. All right. And so a lot of times what you'll find on your exams is that some of your answer choices are going to pull on things that you've learned before. So by you knowing some of this information from before and pulling your information forward, it will help you do process of elimination on your exams. Bronchophony is also a lung assessment. Okay, so if I got to this section and I know that we already tested on the lungs, I would probably, by process of elimination, eliminate bronchophony and resonance because we're not even on the lungs anymore. Does that make sense?
Yes.
That's how I rationalize some things in my head when I'm looking at questions when I was in nursing school. Where are we at? What are we doing? What are we assessing? What should I be finding in this section? Okay.
This time, I just say that you would like to know more about the issue, how this is better functional. Just collect all the best ways to take medication. I'll just say quickly so you can make a better lifestyle and take care.
All right, so iron ingestion can cause black non-terry stool. Okay, so black non-terry stool is literally just black stools. Okay, so someone taking an iron supplement can just have black stools. Black terry stool, let's see. Gina Gallo, can you tell me what causes black terry stool?
A GI bleed.
A GI bleed, okay? Typically some type of upper GI bleed or old GI blood can be coming out, and that's how you'll get that black stool. So basically it's black stool mixed in with some blood. That's what black terry means, okay? Chantel, can you tell me what may cause clay-colored stool?
The absence of bile in the stool.
The absence of bile in the stool can cause clay-colored stool. You can also see it with a bile blockage. Okay, you can also see this with a bile blockage. So make sure, just like we're differentiating what can cause certain urine colors, you guys also want to differentiate what can cause certain stool colors. All right, so everyone got this right. Smoking is a risk factor for osteoporosis. What is osteoporosis? So let's see, Yolande, what's osteoporosis?
Bone density.
So it's a decrease in bone density. Does that make the bone strong or weak?
Weak.
Weak. That makes the bones weak. And when we have decreased bone density, what does that put our patients at risk for?
Fractures.
Fractures. Okay. When we have weak bones, that puts us at risk for fractures. And smoking breaks down our bones because we don't get good circulation to the bones. So smoking breaks down our bones due to poor circulation, which also puts us at increased risk for fractures. Okay. I won't ask. We got other questions that will go over it. All right, so the most reliable range of motion assessment for hip motion dysfunction is abduction. Okay. Whenever I used to try to remember these, I used to always tell myself abduction. All right. Abduction means to move away. So think about someone being abducted and being taken away. So abduction means to move away. All right. And so just think about that picture that was just shown where that leg swings out. All right. So that will let me know how well that hip motion is functioning. All right. How well that hip motion is functioning. So abduction I use to assess for hip motion dysfunction. All right, we're split on this one. So epispadias is when the urethral meatus opens on the ventral side of the glans penis. So it's actually the dorsal side. Okay. Epispadias is when the urethral meatus opens on the dorsal side. Hypospadias is when the urethral meatus opens on the ventral side. Okay, so ventral versus dorsal. Okay, so ventral is going to be your hypospadias. Dorsal is going to be your epispadias. So the way that another way that I remind myself to study is to take out, either you make flashcards, they make concept maps, but you make something that distinguishes one thing from another. A lot of your disorders look the same. Hypospadias and epispadias have the same definitions except for their location. Okay, so once again, hypospadias is going to be the urethral meatus opens on the ventral side, where epispadias is where the urethral meatus opens on the dorsal side. Okay, so ventral meaning under and dorsal meaning upper. Okay. All right. Patient has UTI and low back pain. What assessment might be warranted in this situation? Okay. So correct answer is the costovertebral angle. Let's see. Jenny, can you tell me why we use the costovertebral angle tenderness test? What does that assess for?
The kidneys.
The kidneys. What about the kidneys?
What do you mean by what about them? The location?
Okay, so it's that you said it's assessing for the kidneys. The kidneys are there. Should that test? Should they? What happens when you do that test? How do you do it?
So you place your hand on by the 12 vertebral. The 12. It's between the vertebra and the 12 costal. The 12. What do you call this? Yeah.
Mm-hmm.
And so you palpate, and if you feel something, it means it's inflamed.
Is it a palpation?
I mean, not palpation, but you put your hand there.
Is that all you do? Can we phone a friend? Can anyone else tell me what you do for CVA tenderness?
Is it percussion? You percute to hear the sound?
So it's actually where you take your fist and you hit on each side. So the reason that you do that is because in that lower back area where she was describing anatomically, that's where the kidneys are located. And when you have kidney inflammation, if you take your fist and you hit that area, they'll jump. It'll be pain. Okay. So a normal finding, because we're not assessing for the kidneys there, we're assessing for kidney inflammation to see if there's an issue with the kidneys. Okay. So a normal finding would be that they have no pain. All right. If we hit that area and they have pain, then that is indicative of kidney inflammation. That's what your CVA tenderness is. Okay. So tenderness, because right at that costovertebral angle is where those kidneys sit. All right. And so when we hit that spot, if those kidneys are inflamed, they will have pain. All right. So relate your CVA, you're not assessing for your kidneys, you're assessing for kidney inflammation. All right. Does that make sense? Y'all still with me? Anybody got any questions? Am I confusing y'all? Am I aggravating y'all? Am I making this too difficult? I'm asking my questions a certain way for a reason. Just roll with me. All right. So let's go to the next one. All right, so remember that for this exam, there's going to be some information randomly pulled from, sections that you guys have had in the past, because there's a comprehensive component to this exam. So when we're talking about cerebellar function, Jennifer Acosta, can you tell me what the cerebellum typically, what's the function of the cerebellum?
Can I phone a friend?
Yes. Anyone know what the cerebellum does?
Is it
Has to do with your
movement
balance.
and balance and function?
Balance and coordination. Okay, so our cerebellar function is for balance and coordination. Okay, so of course our Romberg test. Can anybody tell me what we do with that test? Anybody remember?
Isn't it when you have them stand and close their eyes and you see if they can stand up straight without swaying or falling over?
Correct. That is your Romberg test. So that is one test for cerebellar function, because remember we're looking at balance and coordination. All right. Another test that you can do is the heel to shin test. These tests are located on page 641, 642, and 643 if you want to review them. Okay, it's under cerebellar function. But your heel to shin test is going to test your lower extremity coordination by asking the person who is in a supine position to place the heel on the opposite knee and run it down the shin from the knee. Normally, the person moves the heel in a straight line down the shin. Okay, this is testing for coordination. All right. This is testing for coordination. So abnormal finding of this test would be lack of coordination evidenced by their heels falling off their shin. And this would be indicative of some type of cerebellar disease. Okay. So once again, this information starts on page 641 if you guys want to review it.
Definitely. Can be terrible. Definitely.
All right, so this is false. What happens in the Babinski reflex?
You'll take something kind of sharp and make like a C shape on the bottom of their feet and see their toes curl.
Okay. So a positive Babinski sign is curling of toes. So one thing to note is that in babies, this is normal. Okay, up until about the age of 2 to 2.5 is normal for them to have a Babinski reflex. And adults should not have a Babinski reflex. If adults have a Babinski reflex, that means that they have that fanning of their toes when you check Babinski on them. That means that they have some type of issue in their spinal thalamic tract. Okay, and this is on page 680 in your book, or your corticospinal tract. I'll take that back. Corticospinal tract. So if you have a positive Babinski reflex as an adult, that is an abnormal finding. Okay, we should not see a positive Babinski reflex on an adult. Okay, and this is on page 680. And so this is indicative of corticospinal tract disease. You can see this in someone that has something like a stroke or some type of trauma. When I worked in the ICU, I seen this in patients. I didn't see it in any of my stroke patients. I seen it in patients who had who were brain dead. Okay, I seen this in patients who were brain dead. All right, so once again, that is on page 680. All right, so bone mineral density tends to be lower amongst Caucasian women. So Kylie, can you tell me what that means? If Caucasian women have lower bone mineral density, what does that put them at risk for, higher risk for?
Osteoporosis.
Osteoporosis. So osteoporosis is the disease of low bone mineral density, okay? And Caucasian women are at higher risk for osteoporosis. All right, African American women tend to have a higher bone density. So the higher your bone density, the stronger your bones are. The lower your bone density, the weaker your bones are. Okay, so remember that Caucasian women have low bone mineral density, which is going to mean that they are susceptible to weaker bones and osteoporosis. African American women tend to have a higher bone density, which means they are subject to having stronger bones. All right. All right, so osteoporosis can be prevented by walking and weightlifting. So one of the major preventions for osteoporosis is weight-bearing exercise. Okay, weight-bearing exercise, because that will help the bones to become stronger. All right, the more physical weight that we put on our bones, so adipose tissue that's sitting down on our bones, and the more sedentary we are, which means we don't move, so we weigh more, that's going to break our bones down. So we want to move, we want to do weight-bearing exercise, things like weightlifting and walking will help with osteoporosis, so it can help prevent osteoporosis. Okay, so if I had a Caucasian woman and she asked me what could she do to prevent osteoporosis, I would tell her she could do things such as walking and weightlifting. All right, this is false. Okay. Heidi, can you tell me what a pap smear is used for?
It is for cervical cancer.
It is for cervical cancer. Okay, so a pap smear is an exam used to detect cervical cancer. All right, not endometrial cancer, not ovarian cancer, just cervical cancer. Anybody know of any considerations, although we don't perform pap smears, what are some considerations we may take as we're setting up a woman for her pap smear? What are some things we might do to promote her comfort?
Make sure that you're able to have eye contact with her.
Okay, what else?
Ask if they want to urinate first.
Oh yeah, you always ask if they want to urinate first. That's a good one. What else?
Make sure that the bed is positioned away from the door, that they're covered up.
For privacy. What else?
Make sure they're covered.
Make sure they're covered. What else?
Not abducting the legs too far apart.
Yeah, you don't want to abduct the legs too far apart. So putting those legs in those stirrups and really stretching them out apart is uncomfortable. So just remember that when we are setting up someone for a pap smear, it's already an uncomfortable situation. So we want to make sure that as we set them up, we promote as much comfort as possible. Okay. All right. So difficulty urinating and vaginal discharge are indicative of gonorrhea. One thing that you want to know about gonorrhea is just typically they don't have symptoms. Okay. But if they do have symptoms, typically it would be difficulty urinating and vaginal discharge. The thing that should clue you in is the vaginal discharge. Typically with a UTI, they don't have vaginal discharge. Okay. So on page 757 in your books, it says urethritis and UTI, typically what they come in complaining of is difficulty urinating, frequency, urgency, flank, or suprapubic pain. All right. Whereas with gonorrhea on page 761, so their subjective symptoms will be vaginal discharge, dysuria, abnormal uterine bleeding. Okay. So the thing about gonorrhea and UTIs is that they can look alike. Okay. They can mimic each other. So if you have someone come in and they've had a UTI and they've been treated for it and they come back and they're still complaining of the UTI symptoms, we also want to assess them for gonorrhea. So typically, like I said, they're not going to, typically with the UTI, they don't come in complaining of a discharge. They come in complaining of issues with urinating. But as we're asking them these questions about UTI, we also want to ask them about the presence of discharge, because that may cue us into the fact that it's not a UTI, but that it is gonorrhea. In your book, it does say that your anterior vaginal wall shows erythema, pain along the urethra, and maybe purulent discharge, but that typically would be on an inside of the assessment. So when I'm actually doing an assessment of the vagina with the speculum is typically when I would see it. But for the most part, when you have gonorrhea, you actually see a discharge coming out of the vagina, whereas with the UTI, it's typically just issues with urination. Y'all with me?
Yes.
Yes.
All right. Can anybody tell me what dyspareunia is?
Is it pain with sex?
Yep, painful intercourse in older women, typically secondary to menopause, because they lose those estrogen and progesterone hormones, which makes the vagina drier. So they have pain with intercourse.
Oh shit, I don't know. I have no idea.
All right, so raised, firm, and non-tender nodules with freely movable skin. Can anyone tell me what these are called? Anyone know the correct name for these?
A cyst?
Nope.
Papules?
Nope. 14 people said it was false, so you guys knew it wasn't called Bouchard's nodules. So what is it called?
Subcutaneous nodules?
Subcutaneous nodules is what these are called. These are subcutaneous nodules. So remember, with health assessment, you have to know your definitions, your textbook definitions, because a lot of your questions are textbook definitions. This is the textbook definition of subcutaneous nodules. Okay, subcutaneous nodules. What are subcutaneous nodules typically associated with?
Rheumatoid arthritis.
Rheumatoid arthritis. Okay, so you typically see subcutaneous nodules with rheumatoid arthritis. All right, so textbook definition of subcutaneous nodules are raised, firm, and non-tender nodules with freely movable skin. Okay, associated with rheumatoid arthritis. All right, so we should not palpate an enlarged spleen. Why should we not palpate an enlarged spleen?
You can rupture it.
Rupture it, right? It's a high risk for rupture. Okay. Do we normally feel a spleen on normal palpation? No. Okay. And we don't want to palpate a enlarged spleen because it can rupture. All right.